Hello and welcome back to our case review of GI pathology for Step 2 CK. Last time we finished by discussing cirrhosis. We talked about everything we need to know for CK. So let's continue with a new case, a new patient. Okay, so our next case for GI pathology, we have a 47-year-old man who presents to the emergency department with colicky abdominal pain, which has lasted 5 hours. Right off the jump, what are you thinking? Colicky abdominal pain, 5 hours. What's on your differential? Sure, yeah, obstruction too, definitely. Abdominal pain can really be so many different things. Even colicky abdominal pain, they haven't given you an area, obviously, but that's a great differential to start with: appendicitis and small bowel obstruction. So he reports 2 episodes of feculent vomiting and of bowel movement 10 hours ago. Physical examination reveals a temperature of 98.6, pulse of 92, and a blood pressure of 134/90. Abdominal exam reveals distended abdomen, well-healed surgical scars, and diffuse tenderness. High-pitched, hyperactive bowel sounds are noted. No hernias are appreciated, and rectal exam is unremarkable. So, what do you like for a diagnosis here? It's so they haven't described the guarding of peritonitis, or or the rigid abdomen, right? Just sort of a diffuse tenderness is not typical of peritonitis. This is a tough one, but it is one of the items that you liked for your differential diagnosis. So there's a couple things here that really point you towards small bowel obstruction. The first thing is that Sorry? Hello, Daphne? Oh, okay, no problem. So I was just saying that there's 2 major things in this question stem that should point you towards small bowel obstruction. Number 1 is what you hear on the physical exam, these high-pitched, hyperactive bowel sounds. So those high-pitched sounds is really just kind of air kind of squeaking past this small bowel obstruction, or other air that's trapped in the GI tract upstream of the small bowel obstruction. So when you hear those high-pitched sounds, you should start to think of a SBO. The second thing is that they told you about well-healed surgical scars. And so for adults, the most common cause of small bowel obstruction is going to be adhesions. Hey, Daphne. Okay, great. So... Oh. Mm-hmm. 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 Very good. Yeah, excellent. Excellent, good, yeah. Yeah, so he definitely has all the makings of an SBO. Yeah, so most likely we'll go with SBO. What would you want to do next? Surgery. Okay. Yes. Mm-hmm. So really, in terms of relieving small bowel obstruction, in most cases you're going to have to do surgery, especially if it's perforated. This patient, it doesn't seem to be perforated like we talked about before. There's not really a fever. He doesn't have that rigid tenderness. He's not guarding. It's just sort of this diffuse tenderness. So we have a little bit of time, hopefully, before he does perforate his bowel. But that is the one complication we want to avoid. God bless you. Now, before we go to surgery, we're seeing this gentleman in the emergency department. So what's like the first thing we want to do? Imaging, good. Yeah, good. Excellent. So abdominal x-ray is going to be our first step in imaging. Great job. After that, we can do a CT to kind of confirm. But on that abdominal X-ray, we're going to be looking for those dilated loops of bowel, and sort of kind of clue us into that's what the diagnosis is. Okay, and so great. So that's our imaging. In terms of having this patient in the ED, we do need to start IV fluids. We do need to put an NG tube. NG tube, this patient's going to have for quite some time. We're going to place that tube for decompression of the stomach. We're placing a tube because, we don't want him vomiting up, gastric secretions and maybe aspirating them. And so, whenever you have someone with a small bowel obstruction, definitely NG tube is going to be high on your list of things to do. Okay, one of the first things you do. Okay, great. And let's see. Oh, 3 most common causes in adults. That's okay. So let's say that our patient, how do I even ask this? This is a tough one to ask. I'm just going to tell you. So the first one, like you said, is going to be adhesions from, having a history of a surgery some time ago. Second is going to be a hernia. A little bit of bowel, gets through the abdominal wall, and now it gets stuck, and now nothing can progress. And number 3 is, oh my God, I'm actually forgetting number 3. Hold on a second. It's going to come to me. Okay, it'll be on the next slide anyway. Okay, great. So small bowel obstruction. Here we have blocked contents of everything, basically, through the small bowel. We can have a complete obstruction or partial obstruction. Complete obstructions will probably need to be managed with surgery. However, partial obstructions, we don't really want to do surgery for partial obstructions. If we have a patient that comes in with partial, we're going to place that NG tube, and we're going to kind of wait and see and hope that their body can kind of clear out the obstruction on their own. If not, then obviously we will progress to surgery. Most common cause in adults, adhesions from prior abdominal surgery, like you told me before, hernias, and then also neoplasm. This one is surprisingly common, especially something like a GIST tumor or any kind of lymphoma originating from the lymph tissue in the small bowel can cause an obstruction. Okay. For children, the most common cause is going to be hernias. So in terms of symptoms, everything that you told me before. Colicky abdominal pain, nausea, vomiting, obstipation. Passage of stool 6 to 12 hours after symptom onset would be a partial obstruction. So obviously it's not completely obstructed. For bowel sounds, those high-pitched tinkles, peristaltic rushes, the rushing noises is what we look for. If we see fever, hypotension, rebound tenderness, tachycardia, this is going to be our peritonitis. We're going to have to go to the OR because we now have bacteria and just all that feculent material open to the abdomen and causing problems. So we definitely don't want that. In terms of the site of obstruction, the vomiting and distension are going to give you a clue in terms of how high along the GI tract this obstruction is. So if the obstruction is relatively high in the GI tract, we're going to see more vomiting. Compared to lower in the GI tract where we would see more distension. And this becomes important actually when you have patients who have a small bowel obstruction for a longer period of time. For example, you can have a patient with SBO for a week, for 2 weeks, for a month. If they're not vomiting, then they're probably not coming in. They're just saying, oh, I'm constipated, I haven't pooped in a while, this happens sometimes. And then as they get progressively more distended, they kind of get a little bit more concerned, but am I getting distended or am I just kind of getting chubby, And so when you have these obstructions very low in the GI tract, in the jejunum, ileum area, it can get quite large before the patient presents. So, again, X-ray, we're going to see those dilated small bowel loops, air fluid levels, lack of colonic gas. CT can confirm it. And for labs, you can see increased white blood cells and lactate if you have some kind of perforation or a strangulation where you had a little bit of bowel that emerged through a hernia and that bit of bowel is now lacking blood supply. That's considered strangulated, okay? And at that point, basically that bowel is dying, and so you're going to see increased lactate, increased white blood cells. Okay, and so we said before that partial obstruction, we can go ahead and manage that with supportive care. That's really something that, Daphne, I'd like you to, sort of commit and keep in mind for the USMLE, because they are going to want to make sure you know that, right? That for partial, yeah, you don't have to go to the OR every time with partial. NG tube, IV hydration, your patient obviously should be NPO. If any patient that has an NG tube should be NPO, but right, that makes sense. Electrolyte repletion. If we have a complete obstruction or vascular compromise with obstruction for greater than 3 days, then we're going to go to the OR. Okay. Excellent. Any questions on SBO? It's a pretty straightforward one. Yeah, pretty straightforward. Not too tricky in most cases. Just have to know, what to look for and when it's a good time to go to the OR. Great. So our next case, a 47-year-old man presents to the emergency department with mild abdominal pain that he has had for the past 24 hours. He has noticed an increase in his abdominal girth and has been feeling intermittently confused. He adds that last year, wait a second, did we do this case already? Yeah. Does this seem familiar? No. Okay. Anyway, he adds that last year another physician told him that his liver was bad. Physical examination reveals a temperature of 100.8, pulse of 104, blood pressure of 136/74. He is alert and oriented to person and place, unable to provide a correct date. His abdominal exam reveals a distended, non-tender abdomen with shifting dullness. Neurological exam reveals asterixis. Mm-hmm. 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 Excellent. Good. So next best step for this gentleman. Yes, sure. Yeah, we can do IV fluids. You got to give me more than that, though. Mm-hmm. Mm-hmm. Good. 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 Yes, excellent. So one thing that you want to keep an eye out for with patients with, cirrhosis and all this sort of acidic fluid is that bacteria can grow in that fluid, right? Which gives us spontaneous bacterial peritonitis. And so antibiotics are going to be huge here. Very good. Good job. So for SBP, most common bacteria, it's really probably just going to be one of the normal GI bacteria. So E. coli would probably be what you would go for. Yeah, okay, yeah, I thought so. Good. Excellent. So SBP, acute bacterial infection of the peritoneum without a focal source. We're looking for patients with ascites. About 20% of patients with ascites will develop SBP. Okay, that's 1 in 5 patients with ascites. That's a lot. And patients that develop SBP have a over 60% chance of having SBP again. Okay, and so, obviously we're going to talk about prophylactic antibiotics and why that's so important. Most commonly is going to be from a single organism. When we take some of that acidic fluid and we culture it, we'll see one organism. So we'll see E. coli, or we'll see Klebsiella, or we'll see strep pneumo. But you typically won't see a mix of bacteria within that acidic fluid. Okay, and just sort of as a side point, shooting for that 260, 270s, anaerobic bacteria are not typically associated with SBP. All right. And so we're really just looking for one of these 3 bad boys. In terms of symptoms, confusion, abdominal pain, fever, vomiting, and diarrhea. For our physical exam, obviously, this is a bacterial infection, so we will look for a fever. Some abdominal tenderness with rebound tenderness are signs of peritonitis. That distended abdomen with the fluid wave and flank dullness. So, that distended abdomen and fluid wave, that's more of the ascites, right? More than SBP. That's not, doesn't have to be there, but, patients with ascites get this, so. Like you said, we do have some worsening encephalopathy in this patient. This is going to be the most common presenting symptom, okay? So when you see a patient with a fever, encephalopathy, and a history of cirrhosis, you need to start thinking about a bacterial infection of the peritoneal space, okay? That's spontaneous bacterial peritonitis. All right. Yeah, really, honestly, that's the biggest difference. And even in our patient, the fever wasn't that high. But in hepatic encephalopathy, typically it's a progressive course where the patient's just sort of getting worse and worse over the months and years versus someone who rapidly develops encephalopathy. So that would be sort of the way to think about this one is we had a patient with cirrhosis and then all of a sudden he got a lot worse, right? Versus someone with cirrhosis, it kind of takes some time to develop that encephalopathy. Okay. So in terms of diagnosis, we need to do a paracentesis. Okay, we are going to stick a needle into the peritoneal space and drain out some of that fluid. When we drain out that fluid, we can do a lot of testing. We can look at what types of cells are there, look at the bacteria, and really sort of get an idea of where is this acidic fluid coming from and what is the cause of the infection, okay? So white blood cell count over 500 cells is consistent with an infection. A lot of neutrophils in those white blood cells obviously is consistent with the bacterial infection. Gram staining culture for determining the exact cause of SBP. We can look at the pH and lactate, can be helpful. And then last, we need to look at something called the SAG, the SAAG, serum ascites albumin gradient. And what the SAAG is it's really just a formula where we take what our serum albumin is and we subtract from our serum albumin the albumin concentration within the acidic fluid. Okay? Acidic albumin. Okay? And then that's going to give us what our SAG number is. Okay, so before we talk about what is the causes, this 1.1 number, let's sort of think of this big picture. In our serum, what's a normal serum albumin? Yeah, exactly, yeah. So we'll say 2.5. Whoa, hello. So we'll say 2.5 for our serum albumin. And then we have some number for the acidic albumin, and then that gives us the SAG. So if we have a 2.5 serum albumin, and then when we look at the albumin in the acidic fluid, and it's, say, only 0.5, if we have some transudate, we're not going to have much albumin in there. There shouldn't be much protein. So if we take our serum albumin of 2.5, we subtract 0.5 from it, we get a SAAG of 2. Okay? Now that is a serum ascites albumin gradient greater than 1.1, and that tells us that the acidic fluid in this patient's abdomen has a low protein and it has a transudate in origin. Now, let's say we looked at an acidic fluid and it was, instead of 2.5, maybe 2. We'll turn this into 2, okay? Now, acidic fluid with a lot of protein is not transudate anymore, right? Same thing in the lung. When we have pleural fluid that has a lot of protein, then we start to think of a pneumonia. We start to think of a tuberculosis and infections such as these that have a lot of pus and a lot of different proteins in there. Same thing in the ascites. So when you start to see an acidic albumin concentration that's very high, in that case, instead of being a transudate, this is more of an exudate. Okay, and so we start to think about tuberculosis. We think about some sort of malignancy generating all of this extra fluid and all this extra protein. So there, our SAAG would be low. We would have a SAAG of 0.5, which is less than that 1.1 number. And that gives us a clue into the origin of all of this acidic fluid. Okay, and so on the next slide, we have sort of a breakdown of all the different ways we can have changes in that acidic fluid albumin concentration. So first we have this SAAG of greater than 1.1. When you see this number and it's greater than 1.1, that tells you that you have a transudate-like fluid. You have a fluid that doesn't have much protein in it. Okay? Because when we compare it to the albumin of the serum, it's much, much lower, which is how we get such a large number here. Does that make sense? Yeah? Okay, great. So we can have low acidic protein, less than 2.5. That is like our patient who has cirrhosis. We have a lot of transudate fluid that's moving from the portal system and becoming acidic fluid, basically migrating over the walls of the different vasculature. But Chiari syndrome, massive liver metastasis, again, sort of working like cirrhosis, blocking off that portal blood from leaving the portal supply. Okay. We can have acidic protein with a high protein concentration, but if we have a high protein concentration in acidic protein, that means we must have an even higher protein concentration in our serum, right? Because for you to have greater than 2.5, but your SAG is still greater than 1.1, that means your serum concentration must be at least 3.6. Okay, and that's high for your serum protein concentration. So congestive heart failure, constrictive pericarditis, IVC obstruction, sinusoidal obstruction syndrome, these are all sort of the cases there. So in terms of having low SAAG, these are cases where we have more protein in the acidic fluid or less protein in the serum. Okay, so think about a nephrotic syndrome. In nephrotic syndrome, we lose a lot of protein out of the glomerulus. We lose all the albumin, all of our immunoglobulins, some of our clotting proteins we lose out of the kidneys. And so the serum albumin is going to be low. And so when we compare that to the acidic albumin, it's still going to give us a low number, less than 1.1. Okay, and so this is why this is not really a ratio, right? This is just a strict calculation, and that's something important to keep in mind. Okay, great. And so those are sort of all of the cases where we can have these alterations in SAAG. Really, one thing to keep in mind is just really what are you calculating, and that can kind of help you clue into the source of what this acidic fluid is. Okay. Great. So last thing I wanted to talk about is to give antibiotics. Like you told me last time that we met, antibiotics should always be given after we do we take our sample for diagnostic testing. So after we do our paracentesis and drain out some of that fluid that we plan to culture, we are going to give antibiotics. In terms of antibiotics, you want something that is going to be effective against these few bacteria. Fluoroquinolones are frequently given. If it's a more serious infection, our patient's a lot sicker, you can even just go straight to clindamycin, which should be effective in these cases. Okay. Aldosterone antagonists such as spironolactone, and in general, salt reduction is helpful for ascites. Okay. Any questions? Clindamycin. Yeah. Very strong, big gun antibiotic, and it works a lot against a lot of GI bacteria. Okay. Alrighty, great. So yeah, again, our high yield points: acute bacterial infection of the peritoneum, patients with ascites. We're looking for those 3 bacteria. Confusion is really what I want you to look for on that physical exam, along with that fever. You should see some distended abdomen. You may even have that rebound tenderness if the peritonitis has progressed. In terms of treatment after paracentesis, we can give cefoxitim. This is one I didn't mention, but not fluoroquinolones, but cephalosporins can also be good, and these are not really big gun antibiotics, right? Like these are pretty safe to use. These third generation cephalosporins can be good. Ceftriaxone, or you can use a fluoroquinolone with metronidazole, so you get that kind of complete coverage. Aldosterone antagonists such as spironolactone and salt reduction. Okay. Great. So we will move on to our next case here. Great. So here we have a 39-year-old G2 P2 woman who presents to her primary care physician with sensation of undigested food in the back of her throat and chest pain following meals. What jumps to your mind with this particular short history? Okay. So you said Zenker's diverticulum and GERD, right? Yeah, okay. So great. So she reports difficulty swallowing foods and liquids that started during her last pregnancy, has continued over the past year following delivery. Multiple occasions she's found undigested food in the pillow in the morning. Not great. So she reports losing 12 pounds over the past 2 months due to discomfort she feels after eating. She's been taking famotidine and omeprazole for her symptoms, but reports no relief. Physical exams normal. Abdomen's non-tender, non-distended, soft, normal bowel sounds. So most likely diagnosis for this particular patient. Okay, so she certainly has something that's preventing food from making it to the stomach, right? And when it comes to Zenker's diverticulum, definitely undigested food, that's a big part of that diagnosis. But some of the things that kind of push us away from Zenker's here. Number one, Zenker's doesn't really explain the chest pain after eating. You said GERD initially, which I agree with 100%, but the fact that the GERD is not being relieved by famotidine and omeprazole is kind of concerning and makes us not want to think GERD. And so, because Zenker's can't really cause that chest pain by itself, and we're not in the real world where we can have multiple diagnoses, we have to find something that kind of encapsulates all of these symptoms. Okay. And so we have a patient here who's essentially has something that's not allowing food to get from her mouth through the esophagus and to the stomach, right? We know it's not getting to the stomach because she's not reporting vomiting, right? She's just reporting regurgitation, really. And so in terms of things that can prevent food from getting from the mouth to the stomach, what are some of the options there? Sure. No. Yeah, you're right. It wouldn't be necessarily a hernia. A hernia definitely would present with more GERD-like symptoms. Just from all the acid coming up out of the stomach. So some of the things we want to look for are things that are going to cause an obstruction in the esophagus. So just as good. Yep. So esophageal rings, the Schatzki's rings. That's one. Good. Good. So neoplasm as well. That's definitely something that we want to keep on our differential if it's a possibility. Great. So neoplasm. And then the last one, and I know you're going to kick yourself after I say the word, but the last one is achalasia. Right? So achalasia is really where the lower esophageal sphincter just kind of decides it doesn't want to relax anymore. And now whenever our patients eat, we just sort of have accumulation of food upstream of our stomach. And so some of the things that we can use to differentiate between those esophageal webs and achalasia. Esophageal webs, patients are going to have difficulty with solids. It's really going to be solids only versus achalasia or neoplasms where both liquids and solids can't really progress past that obstruction. Okay, so for this particular patient, she reports difficulty with solids and liquids. And so if we had options in a question stem, right? So, I make this more difficult for you because I think that it's going to help you in the way that you think about patients as you read through these question stems. If I gave you option choices of Zenker's diverticulum, esophageal webs, achalasia, and something else, I'm pretty sure you would have picked achalasia, right? You would have seen that word and you would have said, okay, wait a second, and then look back and picked achalasia. I'm pretty confident about that. You have a very good knowledge base. You understand what's going on with these patients. But not having the option choices really helps you learn about the patient presentations, right? Because there's little nuggets of gold in these patient presentations that they give you that can help you get to that right answer, okay? So great. So achalasia is going to be our diagnosis here. For next best step, so diagnostically, what kind of test do you like for achalasia? Good. Yes, excellent. Manometry will tell us where is the pressure in the esophagus and really look at sort of the peristalsis, what's going on there. Good. So manometry is good. We can also do a barium swallow and look for a certain kind of sign, right? The bird's beak. Yeah. Yes, good. Yeah, you're absolutely right. Manometry is an excellent answer and something that they definitely want you to know. Yeah, you're right about that. Okay. While we can't do an NG tube, we should try and decompress her esophagus. So just sort of a nasoesophageal tube might be a good thing to do here as well. Okay. And last, treatment strategies for achalasia. Mm-hmm. Mm-hmm. Good. Excellent. So those would be our medical treatments, and then just surgically opening up that lower esophageal sphincter, right? Doing a myotomy, cutting out some of that muscle, and then relieving that obstruction. So, great. LES relaxation is the big problem here. Sprinkle of esophageal dysmotility. Just sort of as, again, like with your step one review, but it is a progressive degeneration of the Auerbach plexus, especially the ganglion cells of myenteric plexus. Okay. Primary could be idiopathic, such as in the woman in our question stem. Secondary, we have our trypanosoma, autonomic neuropathy. This is really one that you should sort of put a pin in this and keep in mind is that patients with diabetes, any part of the body that's dependent on, your parasympathetics or, these deep visceral plexuses, diabetes can affect that. Okay, so you can have gastroparesis where your stomach stops churning and breaking up your food. You can have, anywhere in your GI tract, you can have diabetes can have an effect there, and so esophagus is included there as well. Amyloidosis can result in deposition of protein in the wall of your esophagus and sort of degenerate that plexus. For our idiopathic patients, like the woman in our question, it involves some sort of autoantibody that causes a loss of these nitric oxide-producing inhibitory neurons, so you cannot relax that esophageal smooth muscle. Dysphagia for solids and liquids is really going to be our helpful hint in the question stem. Barium swallow is going to show you a dilated esophagus and tapering to the bird's beak. If you instead saw a corkscrew pattern, where when we did the barium swallow, I'm just going to utilize my art school degree here. When we do our barium swallow, here's our esophagus, and our esophagus looks a bit like this, and here's our stomach going to our duodenum. Here's our esophagus like this. Here's our stomach going to the duodenum. And so here you can see the esophagus sort of has this corkscrew side-to-side pattern. This patient, instead of having achalasia, has something called diffuse esophageal spasm. Okay, diffuse esophageal spasm was something I never heard of until I started studying for step 2. I certainly never saw it during my clinical rotations, but essentially what it is, you have a patient who presents almost as if they are having a heart attack. They're going to say that they were eating their dinner and suddenly they had this severe chest pain, retrosternal, that's not really relieved with rest, and you're going to be like, oh my God, we have to get an EKG. EKG is completely normal, and then you find out that they're regurgitating food. You should start thinking about this diffuse esophageal spasm. This is a disorder where it's really just as it's described. Intermittently, when your patient is eating, as the food is moving down the esophagus and some of those peristaltic waves are coming down, there's some sort of disordered transmission of those signals causing all of the muscles, or most of the muscle in the wall of the esophagus, to suddenly clench up and spasm. Okay, and so that's what's going to give your patient those symptoms. Okay. Yes, there should be some regurgitation as part of this, yeah. Because your patient with, a heart attack is not going to be regurgitating food. So that should be one of the biggest things that kind of clue you in, right? So, yeah, great. Manometry revealing normal to elevated pressures in the distal esophagus is the gold standard, and definitely would confirm our diagnosis. The treatment goal, we need to dilate that distal esophagus medically or mechanically. So our first line is going to be just to go in there surgically, take out a bit of muscle. It's called a sphincter myotomy, and for most patients, that's going to be pretty successful. Okay, that should be good enough. However, if you have a patient that maybe doesn't want surgery, we also have the option of balloon dilation, where we slide a balloon down here to the distal esophagus, and then once we get it, close to this obstruction, we dilate the balloon and cause a dilation of that distal esophagus. So this is actually pretty successful as well. 80% is not bad, right? However, there's a 3% complication rate with this particular procedure. Okay, and so the complication, obviously, that we're looking for is going to be a perforation of the esophagus. Now, if you perforate someone's esophagus, that's not good. Okay, now we have blood and just everything from the esophagus leaking into our thorax where our lungs are. It's not good. So while balloon dilation is a pretty successful procedure, that risk of complications makes it a procedure that many gastroenterologists won't want to do. Okay. Exactly. Yes. Sphincter myotomy is going to be the first line. These medications that dilate the distal esophagus, it's not great. They have a very low success rate in terms of working. There's also this option of local Botox injections, but that typically that's rare. Usually, for your answer choices, look for sphincter myotomy being the first thing you want to do. Balloon dilation is an option too, but keep in mind that chance of complications. And the other thing with balloon dilation is when you dilate that distal lower esophageal sphincter, great, now food can go through, but food can also come back now. And we're going to have acid coming back, right? So we can be concerned about GERD, and that GERD progressing to, dysplasia of the tissue down there. So that's something to keep in mind as well. Not only are we having the complication of perforation of the esophagus, but also long-term complication of Barrett's esophagus. Okay. Regardless of what treatment strategy we utilize, these patients have an increased risk of squamous cell carcinoma of the esophagus. Okay, and this is an especially important point because when we talk about different types of cancer of the esophagus, the sort of thing we get indoctrinated when we study for step 1 is that for the lower third of the esophagus, it's all adenocarcinoma, and then for the upper 2/3 of the esophagus, it's all squamous cell carcinoma. This is one way that you can have a squamous cell carcinoma in the lower 1/3 of the esophagus. Okay. Otherwise, typically cancer of the lower esophagus would be an adenocarcinoma coming from that Barrett's esophagus, right? Okay. And sort of the last thing that I'll mention here about achalasia, before we talk briefly about manometry, is that the location of the obstruction in the esophagus can also clue you into the diagnosis. And so if they were to tell you that you had an obstruction a little bit higher up, say in the proximal esophagus, in that case you would think more webs. And then a distal obstruction, you would think more achalasia or some sort of malignancy. Okay, great. Okay, great. So for our manometry, just a quick review. When we look at our normal manometry, you can see here that our towards the upper esophageal sphincter, we have a rapid relaxation, a rapid increase in pressure, and then otherwise, the upper esophageal sphincter has a level of pressure at all times of about, say, 100, right? This is right in the middle, so we'll say it's about 100. So that's typically going to stay closed most of the time. Now, as our bolus of food progresses down the esophagus, what we see is these almost looking like action potential type increases of pressure. And as we move further down the esophagus in time, you can see that the pressure sort of moves forward, propelling that food towards the stomach. When we get to the lower esophageal sphincter, we have a steady state pressure of about 40. When that food bolus reaches the lower esophageal sphincter, it's going to relax and then close behind that bolus, okay, and return to that pressure of about 40. In our patients with achalasia, what we see is sort of what we just described. So our upper esophageal sphincter is fine, great. We have an action potential, looks a little bit weaker than the normal one, but it's there. As we move down the esophagus, what we see is that we have some sort of process involving the wall of this esophagus. So the muscles there are not contracting as they should. So we're going to see weak peristaltic waves as we progress to the lower esophageal sphincter. When we get to the lower esophageal sphincter, what we're going to see is that it is not relaxing. So we have... Hey. Yeah, no problem. So for achalasia, what we see is in the upper esophagus, we have normal esophageal peristalsis, great, looking good. As we start to progress towards the lower esophageal sphincter, our peristaltic waves are going to get weaker and weaker. Okay, so you can see that this peristaltic wave is a lot smaller than our normal peristaltic wave. And that's because we have, whether it's from amyloidosis, where we're having deposition of protein and sort of disordering that signaling, or we have those autoantibodies that are destroying the myenteric plexus nerves, whatever it is, the muscle in the wall of the esophagus is not contracting as well as it should, and so peristalsis is weaker. Okay. Now, when we get to the lower esophageal sphincter, what we see is that we have a very high pressure, higher than normal, right? Normal was 40. This looks like it's at about 60. We have a much higher pressure, and when the peristaltic wave reaches the lower esophageal sphincter, we have very little, if any, relaxation. And so, yes, this pressure does relax from 60 to maybe 55. However, 55 is still quite high, and so food is not going to be able to move past this obstruction. Okay, so what we look for on manometry is weak peristalsis throughout the esophagus and a lower esophageal sphincter that does not want to relax. Okay, and so there's these images down here that kind of show you what is seen on manometry. I would never be able to interpret this, and I don't think you really need to be able to. If you can explain this to me, I would love you for it, because I really have no idea what's going on. But apparently you can see it on here. For our scleroderma, in scleroderma we have deposition of all of this scar tissue fiber in the wall of the esophagus. I think it's called esophageal dysmotility in the when it's being described in scleroderma. So we're going to look for, again, weak peristaltic waves in our esophagus, and then when we get to our lower esophageal sphincter, it's different from achalasia, because here, instead of having that inability to relax, we really have more of an inability to contract. Okay, and so you see here we have a very low pressure. The pressure here is maybe 20, and when we have that relaxation, not much happens. Okay, and so for scleroderma, rather than having some sort of obstructive type picture, it's really going to be presenting more with GERD. Okay, because we have acid coming back up into the esophagus. All right. And last, for our DES we talked about before, I mean, look at this. What is happening here? You can see we have these really intense contractions of the esophagus. At the lower esophageal sphincter, we have this really intense relaxation with the LES remaining open for quite some time. Okay? All right, so these are really the only three things you would ever be asked about on manometry, so I wanted to just briefly go over them in the context of achalasia. Okay? All right? Good. Okay, so high yield points. You got all this stuff. This is good. You're good on this. Okay? So, 25-year-old woman presents to her primary care physician for recurrent abdominal pain. Describes having daily episodes of crampy lower abdominal pain and diarrhea for the past 6 months. Diarrhea has occasionally been bloody. She's experienced an unintentional weight loss of 10 pounds over the past 3 months, and adds she has also had a subjective fever several nights last week. Physical exam reveals a temperature of 100.1, pulse of 96, appears thin, is in no acute distress. Abdominal exam reveals diffuse tenderness. Rectal exam significant for frank blood. Good, excellent. That's exactly where you should be at this point. Thinking of IBD. Trying to differentiate between UC and UC and Crohn's here is a little bit tricky because we have little bits in the history that point towards Crohn's, and we have little bits that point towards UC. And so I love that you said that you're between those two, because that's exactly where you should be. Okay, great. What is required for diagnosis? How do we confirm exactly what the diagnosis is here? We really see more bleeding than in Crohn's, and so that kind of takes the priority in terms of diagnosis. Especially, frank blood at the rectum tells us that we're having some sort of involvement very close to the rectum, and really involvement of rectum, I always think of UC, right? Because that's where it starts. It starts at the rectum and it just progresses proximally. And so when they're telling us that there's blood at the rectum, I'm definitely thinking more UC. Now, I believe I heard you say that for confirmation and diagnosis, you need a biopsy, correct? 100% correct. That is what I was looking for here. When you are trying to confirm this diagnosis, you must get a biopsy. And that will, on histology, you'll be able to see what the diagnosis is. Okay, so treatment strategies. If you can just name one of the medications that's given in IBD, I'll be happy. What are some of the medications that we give these patients? Mesalamine. Yes, great. Mesalamine. Yep. So mesalamine, sulfasalazine, those are going to be our two anti-inflammatory drugs. They work through the COX pathway, and those really decrease the inflammation at our GI tract because they don't really become active until they reach the colon. Okay, so those are really great drugs. This is also, has this autoimmune component to it, so you can give corticosteroids and, sort of tamp down the immune system is another good strategy. Okay, great, excellent. So inflammatory bowel disease, UC versus Crohn's, just sort of our step 1 level review here. UC is really a mucosal disease with the rectum and going proximally. We're looking for younger patients and common in Caucasians. For Crohn's disease, this is going to be a transmural involvement of the wall. Can affect any part of the GI tract from the lips to the anus, essentially. Bimodal age distribution. So we're looking for younger patients or older patients, but it typically wouldn't be someone who is, 45 years old presenting with Crohn's disease, okay, for whatever reason. Women are affected more often than men, but it's perfectly possible to see men with Crohn's disease. Don't make that your way to diagnose this, okay? Smoking, for whatever reason, increases your risk of Crohn's disease, but it decreases your risk of UC. So interesting tidbit there. In terms of symptoms, for Crohn's disease, we're looking for abdominal pain, low-grade fever, weight loss, watery diarrhea, perianal fissures, fistulas. This is all really all the things we look for with Crohn's disease. Okay. In terms of fistulas, we can have if it's a female, a colovaginal fistula, and in that case, we should have a patient who presents, with describing, having some sort of discharge, very, malodorous discharge. You can also have a colovesicular fistula. Okay, and so a patient with a colovesicular fistula has a fistula between the colon and the bladder. And that patient is going to be complaining of frothy urine, okay? A lot of bubbles, a lot of, obviously, odor whenever they use the bathroom. And dark, yep, exactly. Yep, dark urine. All of these things together sort of give you that picture, okay? They can have fistulas between the colon and the skin, okay? And something that you really have to manage gently. And that's pretty much it. So for UC, we look for that bloody diarrhea, like you told me before, tenesmus, and crampy abdominal pain. For diagnosis here, CBC, we can look for a white count, abdominal X-ray. Abdominal X-ray we want to do in our patients with ulcerative colitis. Why? What are we looking for? Very good, excellent. Toxic megacolon, something that we need to quickly go to surgery to remove the colon in that case. Stool examination for bacteria, C. diff, toxin, oviparasites. Obviously, all that stuff's going to be negative, but when you have a patient that's presenting with this colitis type picture, you want to just sort of rule all these things out anyway. Okay, and so all that is within the realm of acceptable answers in terms of treating a patient when you don't know the diagnosis. Colonoscopy with biopsy, we need that for diagnosis. We can do a barium enema. The barium enema goal is to sort of see those early changes that you see in inflammatory bowel disease. Some of the thickening of the wall of the bowel you can see in Crohn's disease. And just a lot of inflammatory changes. Maybe some stricture you can look for with Crohn's disease as well. Okay. In terms of ulcerative colitis, we really look for that lead pipe picture where just the wall of the colon is missing its haustra, right? It's missing those little divots. Both in terms of treatment, both UC and Crohn's disease are going to be treated with that sulfasalazine, mesalamine. We can give corticosteroids for disease that's refractory to sulfasalazine and mesalamine or to induce remission. Okay, so in the acute phase of our patients with these diseases, when we want to stop that acute phase, we're going to give sulfasalazine, we're going to give corticosteroids. We're going to give all of that at once. And once our patient is back in remission, we can switch to just giving a sulfasalazine. Okay, we don't need to be giving corticosteroids for an extended period of time. Okay. For UC, colectomy is going to be curative, and it's definitely something that we want to keep in mind considering this risk of colorectal carcinoma. Okay. And so that's one thing to keep in mind as well. We're going to begin our FOBT colonoscopy 8 years after our diagnosis. That's, one of those high yield things that the CK is going to ask you about, right? Yeah. Okay. Okay, great. Any questions on IBD? No? Okay, good. Good. Okay, so we have one more case here. A 50-year-old surgeon presents to his primary care physician 2 to 3 week history of fatigue, right upper quadrant discomfort. In the past week, he's noticed yellowing of his eyes. Previously healthy, no medical problems. However, several months ago, while supervising a new intern on a trauma case, he was accidentally struck with a needle. Did not seek medical care at that time and thinks the patient may have been a drug user. Physical exams notable for jaundice, hepatomegaly, right upper quadrant tenderness. Labs include, vastly elevated bilies. We have an increased AST and ALT, increased alk phos, INRs, pretty normal there. We sent for HBsAg, HBeAg, and HBV DNA, and we see that is positive. Okay. Anti-HBs, anti-HBe is negative. Okay, so what are we thinking this gentleman has? chronic Hep B. Good. Okay, so viral hepatitis in general. For the acute phase, we look for transaminase levels in the 100 to 5,000 range, vastly elevated transaminases. Our symptoms are going to be systemic. Look for fever, nausea, vomiting, fatigue, malaise. Those are all sort of our B symptoms of hepatitis. For the acute infection, hepatomegaly, fever, nausea, liver tenderness. As we progress late, we're going to have jaundice. Okay, so this should have been a late presentation of infection rather than the acute phase of infection. When you get to that late stage, you're also going to have right upper quadrant pain, not tenderness where we're pressing on that right upper quadrant, but just the patient complaining of just generalized pain in that area. Okay, a little bit different than in the acute phase. In terms of diagnosis, you have that vastly increased AST, ALT. You're going to have increased bilies. For chronic hepatitis, you can look for hypoalbuminemia as the liver starts to fail and stops making those proteins. Prolonged PT. Every one of the coag proteins except factor VIII is made by the liver. And so all of those factors are going to be down. So look for that prolonged PT. Viral serology as well. I think for the step 2, the biggest change from step 1 is in terms of how much we have to know about treatment. Okay, so I left in a few other types of hepatitis just as a general review. If you have a patient who is a severe alcoholic and presents with hepatitis, that patient should get steroids. Okay, that patient should get steroids. A patient with immunosuppression, with autoimmune hepatitis. You're going to want to use steroids, azathioprine, things that work on the cellular level to tamp down the immune system. Okay, that's our autoimmune hepatitis. For chronic HBV, like in the gentleman in our question stem, we can use interferon alpha, lamivudine, and adofovir. Okay, those are going to be our go-to drugs for chronic HBV. For HCV, we have our pegylated interferon, ribavirin. There's some newer drugs. So fosfobir is really the big drug now for chronic HCV. However, I'm not sure if that's going to be on your exam or not, but it's a good one to memorize as well for HCV. When our patients progress to end-stage liver failure, if they do, liver transplant is really the only curative measure that we can take. ICU management, emergent transplant for fulminant hepatic failure. So when you have that patient who attempted suicide by acetaminophen toxicity, that patient is going to need to get a liver transplant, okay? Or any of these patients that have that viral hepatitis where it has progressed to a point where you have complete liver failure, you need to do a transplant, okay? Okay. Any questions on hepatitis? Like I said, it's really very similar to what you needed to know for step 1. It's really just the drugs that you need to know that's different. So here are some of our serologic markers. Our Hep A antibody is the best test to detect active hepatitis A. Hepatitis A never goes chronic, so we don't really look for IgGs in a patient with Hep A, right? Because if our patient has hepatitis and we see IgGs, Hep A is not the cause because it doesn't go chronic. Okay? Hopefully that makes sense. Surface antigen, this is carrier state. If we see that, a surface antibody tells us that we have immunity to HBV. Core antigen is just one of the parts of that virus as it's assembling its progeny. Core is going to be one of those antigen that it assembles. Another thing that we can detect, doesn't really have a lot of clinical utility, but it's there. Antibody this is helpful because it's positive during our window period. During the window period, you remember from step 1 is where all of our surface antibody and all of our surface antigen are kind of bound together, and so testing for either of those comes up negative. So we can become confused and say, oh, our patient doesn't have Hep B. But really what's going on is that they're just both occupied with one another, and so we can't see them. That's our window period. So during that window period, we can test for a core antibody, and that should still be positive. Okay. HBe antigen. This is an important one for step 2 as well, knowing that HBe antigen is an indicator of transmissibility. our patient is infectious if they have this antigen around. Okay, and the antibody to that antigen means low transmissibility. Alrighty. So again, I know this is really step one level stuff, but you got to know this stuff too. Okay, and that's sort of all she wrote for hepatitis. Any questions on viral hepatitis? No. Mm-hmm. For hepatitis, honestly, it's really just the drugs that you need to be really comfortable with. Sort of the nuances between these different types of viral hepatitis. For example, that Hep B tends to be acute. 80% of the time, it's an acute hepatitis, and only 10% chronic. But that's reversed for Hep C. Knowing which of the hepatidities are naked, which of them are enveloped. I guess that's step one too. Yeah, it's really hard. I'm trying to think of things that they can really add on to make it more difficult for step two. But there's just honestly, Daphne, there's not that much. There's not that much. It's really kind of step one level stuff with meds. Yeah. So as we think about these different types of viral hepatitis, we need to consider what is the most likely cause, what's the most likely etiology of the infection with hepatitis. A and E are fecal oral, obviously. Those are fecal oral transmission. For B, C, and D, it's not fecal oral. So we need to really have a way of thinking about what was the most likely way our patient was infected. Yeah, so Hep B, I always think of just like sex type stuff with Hep B. So sexual transmission is very, very prominent for Hep B. And then also parenteral with childbirth is the other big transmission for Hep B. And one thing I want to add there is that, so yes, I did tell you, and I didn't lie, I told you that Hep B tends to be acute. However, when it's transmitted parenterally from mother to child during childbirth, that tends to be chronic. Okay, so babies that get affected with Hep B, it's a huge number. Something like 70, 80, 90% of babies infected with Hep B have chronic Hep B. Okay, so sort of another nuance. Yeah. Mm-hmm. Right. Good. Mm-hmm. Good. Yeah. Any needle sticks, tattoos, drug users, those are going to be our high yield. Needle sticks, I think, is the most common cause of Hep C. If not IV drug use, I'd have to look. Actually, I'm not sure about that statistic. Don't write that one down. But yeah, definitely everything involving needles is sort of how I associate Hep C. Okay, and Hep C really tends to be chronic. The other thing about Hep C is that most people with Hep C are asymptomatic for a long, long time. Okay, patients with Hep C tend to be diagnosed because they are having some sort of treatment for something else, right? So if it's an IV drug user, maybe they came in for an endocarditis. We did a test for Hep C just to rule it out, and we see that it comes back positive. Okay, and so we'll see those IgGs for Hep C. And the other thing about Hep C, and this might be more step one stuff, but just know that IgGs for Hep C are not protective because Hep C has that ability to mutate its capsule and really change how it looks. And so, our antibodies are not going to be that effective against preventing infection with Hep C. Okay. Alrighty. I think that's it for this lecture for GI. Was there any other topic in GI that you wanted me to go over or that you had questions about? Obviously, I didn't go over everything, but I tried to hit the really high yield disorders and diagnoses. Oh, for peds? Uh-huh. Yes. Mm-hmm. Mm-hmm. Yeah. Yeah, no, there is a good amount. There is a good amount, especially when it comes to liver stuff. All of our, you know, Reuben Dubin Johnson and all those rotor, all that good stuff. Stuff that presents at childbirth versus stuff that presents later. Yeah. So okay, so we'll do that on Tuesday. We'll talk about peds GI, and then we should be able to kind of shut the door on GI for a while, and we can move on to another topic when we meet again on I believe Sunday. We're meeting again after that. The nice thing, Daphne, is that after this week, I'm done with all of my interviews. I sent you my whole schedule. You know what my schedule is like. So I'll definitely be more free to meet up. If you want to make up that day that we missed last week, we can definitely fit it in really any day after this week. Okay? It really gets opened up. Okay, great. So really good work today. And I look forward to meeting with you